Assalamu alaikum everybody, sabah al-khair. Okay, so in the next 17 to 20 minutes, I'm going to give you a run through recognizing different types of diabetes beyond the traditional types of diabetes that we look for. And so when we look at diabetes, most physicians think that it's either going to be this type, which is typically type 1, or it's going to be this type, which is typically type 2. Occasionally, very occasionally, we think about this type, which is, anybody? Maybe Modi or LADA, as you said. But what I want you to hopefully, when my lecture's finished, walk away with is an idea that there's actually probably a number of additional important subtypes of diabetes that we currently are lumping into either type 1 or type 2. So the typical type 1 diabetes is, of course, that which develops at any point during childhood and peaks at around puberty. And cases as young as 6 months have been described, although there is a specific form of diabetes which is congenital diabetes, which is of course present in very young. Most patients present before the age of 40. However, it is important to recognize that 1 in 5 people develop type 1 diabetes over the age of 40, and in fact, Theresa May, you may recognize as the previous Prime Minister, diagnosed with type 1 diabetes at the age of 57. And for about 6 months, actually she was seen by her physicians and they thought she had type 2 diabetes. But the reason why she has type 1 diabetes, you can see she has the sensor on as well. Okay, so it is important to note that older people can get type 1 diabetes. In terms of common or garden type 1 diabetes, we know that the risk of developing type 1 diabetes is determined by HLA-DRDQ genes, which can either predispose or confer protection from type 1 diabetes. We also know that there are environmental factors which include exposure to certain viruses, cow's milk protein, change in the gut microbiome, and vitamin D deficiency, which may increase the risk of type 1 diabetes. And also, we are aware of a number of antibodies which are present against beta cells, which include islet cell autoantibodies, insulin autoantibodies, and of course anti-GAD, and autoantibodies, tyrosine phosphatase, IA2, IA2 beta, and zinc transporter antibodies. So we know that this is an immune process which may be modified by the environment. And in fact, there is a recent study published in Nature Medicine called from the TEDdy study group, which looked at 7,000 children over 9.3 years to determine how we might be able to predict these patients who might develop type 1 diabetes. And traditionally, of course, we think about having the age of the patient and a positive family history. So if you have a sibling that has type 1 diabetes, you are increased risk of diabetes. But actually, if you look at the predictive ability, the area under the curve, it's not really that great. So family history, whilst important, is not really that predictive. However, we know that the presence of autoantibodies in a sibling who has not yet got diabetes, but if you find antibodies, you know that that increases your risk of developing type 1 diabetes. But we also know that 12 to 15% of people with overt type 1 diabetes have no antibodies, and there are other conditions, for example, stiff man syndrome, where anti-GAD antibodies are highly elevated, but it has nothing to do with autoimmunity of the beta cells. But these investigators actually used a combination of family history with autoantibody status, and they came up with this score, which actually predicts with almost 96% certainty whether or not the sibling will develop diabetes compared to those who don't develop diabetes over a period of 9 years. And you can see here the AUC differentiating those people who developed diabetes, were free of diabetes compared to those who developed type 1 diabetes was 0.96. And this is a score that's available that you can use to predict whether or not somebody gets diabetes. So that's type 1 diabetes in a nutshell. But what about other variants of type 1 diabetes? I want to illustrate this by way of a case. This is something called fulminant type 1 diabetes. Okay? So this is actually a case of a 26-year-old Cambodian man who was admitted to the emergency department in Marseille during the COVID-19 outbreak. He had a 6-day history of nausea and abdominal pain, but importantly, he had no polyuria, no polydipsia, no weight loss, and his BMI was 20. He was in a confusional state, apyrexial, and lowish blood pressure. He was acidotic and he had ketonuria. But look at his glucose level. It was extremely high, 60.5 millimoles per liter, 1,100 milligrams per deciliter. However, look at his HbA1c, 6.2%, and his renal function was markedly deranged. CRP was elevated, procalcitonin normal, and actually they initially thought he had SARS, but he didn't. PCR was negative. And when they checked his antibodies, the GAD, islet antigen, insulin, zinc transporter, all negative. So this young man had markedly elevated glucose, and you would think at this age he's got type 1 diabetes, but he's got no antibodies. However, when they did a glucagon test to assess insulin secretion, they found that the serum C-peptide was markedly low. Now, what does that tell you? That tells you that his beta cells are not working, despite the fact that he's got no antibodies. And in fact, they went on to do a number of investigations to looking for actually whether or not he'd got pancreatitis, and in fact, he didn't. So he had a normal pancreas. He did, of course, have pneumonia that he was admitted with. So what is fulminant type 1 diabetes? Well, fulminant type 1 diabetes originally actually was described in the Far East, in Japan, and essentially it is type 1 diabetes, but it's slightly different in that in classical type 1 diabetes, what you have is you have this process over maybe even up to 12 months or a year, where you get this progressive autoimmune process, which then results in, over a period of maybe several years, eventually very few beta cells. In fulminant type 1 diabetes, you actually have completely normal beta cell mass, but then something happens that triggers a massive reduction in beta cell mass, and so that's why the patient presents acutely unwell with very high levels of glucose and ketones. And in fact, this is actually a Japanese investigator who've put together the criteria. So the criteria for fulminant type 1 diabetes is the occurrence of diabetic ketosis or ketoacidosis within 7 days of the onset of hyperglycemic symptoms, a plasma glucose level which has to be more than 16 millimoles per liter, and a urinary C-peptide excretion less than 10 micrograms. The other findings in fulminant type 1 diabetes are that they don't have antibodies, but and their duration of disease before the start of insulin treatment can be only 1 to 2 weeks. And they also have elevation of serum pancreatic enzyme levels. Amylase, lipase, or elastase can be increased in up to 98% of people, suggesting that there is some intrinsic pathology within the pancreas. So, the characteristics are presentation with ketoacidosis, a normal HbA1c, no antibodies, no C-peptide. The other new form of diabetes that we need to now recognize, and we are recognizing actually in the UK and in the cancer unit in Hamad, is this diabetes, which is related to a new set of drugs which are very, very good drugs for cancer, but they have a side effect, which is they cause diabetes. So the immune checkpoint inhibitors are essentially based on a mechanism of action, which is that normally what happens is that you have program death 1, which is a cell surface molecule which is expressed on T cells and B cells. Normally what happens is that PDL1 and PDL2 bind to PD1 and they inhibit T cell proliferation, causing the self-tolerance phenomena. So essentially, if you have a T cell, normally it will attack cancer cells, okay? It won't attack cancer cells, so there'll be self-tolerance. Now, if you have these new drugs, CTLA-4 antibodies or PDL1 antibodies, what they do is they disrupt this, and they actually, not only do they allow the death of cancer cells by the T cells, but also, as a side effect, they actually attack beta cells in a small proportion of patients. And so, you have these CPIs, which are these checkpoint inhibitors, which are nivolumab and pembrolizumab, or PDL1 inhibitors, and they can actually cause endocrine dysfunction, so hypophysitis, thyroiditis, diabetes, and it's acute onset diabetic ketoacidosis. So you will have a patient who's got cancer, who's doing very well on these PDL5 inhibitors, and suddenly they become seriously ill and they'll present with ketoacidosis. Now, they also have anti-GAD antibodies because this is an immune-mediated abnormality, and they may have an asymptomatic lipase elevation. All in all, these are the major types of diabetes that you will see with checkpoint inhibitor therapy. So with the PD-1 inhibitors, with CTLA-4 inhibitors or PD-L1 inhibitors, you can get this CPI checkpoint inhibitor-related diabetes. So there is this acquired lipodystrophy, where you have subcutaneous adipose tissue dysfunction, low levels of leptin, severe insulin resistance, hypertriglyceridemia, but normal C-peptide levels. Here, it's insulin resistance that is driving the diabetes. Whereas you also can get an autoimmune pancreatitis, you can get this temporary typical type 1 diabetes, and then there are these chronic insulin-dependent diabetes type of diabetes, which is the fulminant type of diabetes, where you can have positive anti-GAD, extremely fast and massive beta cell injury. You can have this typical, usual type of type 1 diabetes, and then there is this type 1 diabetes, which is with positive anti-GAD antibodies. So there's multiple different forms of autoimmune destruction of of beta cells. The other subgroup of patients who, again, we think have type 1 diabetes, but actually have a different type of diabetes, is this ketosis-prone diabetes. Originally described in 1994 in a place called Flatbush in the USA. And the typical presentation here is that the patient will present with fulminant, well, not fulminant, but diabetic ketoacidosis. But they don't have to remain on insulin. About 50% of these people actually will recover, and you can take them off insulin or even other oral therapies. And the reason is, and actually originally they were described just in African American men, but now we know that Hispanic, Asian, South Asian and Caucasian people also develop this Flatbush diabetes. And essentially what you have to think about is whether or not these patients, there are 4 subgroups, whether or not they have antibodies and or beta cell function. So you have the first class, which is A plus beta minus, which is antibodies present, beta cell function absent. In these people, you need insulin. If you have antibodies present, but the beta cells are working, then actually you can manage them with oral medication and or insulin. If there are antibodies negative and beta cell function is absent, you need insulin. And if you have antibodies negative but the beta cell function is present, that's about 50%, you can actually stop insulin after their acute presentation. And this grouping actually has 99% specificity and 96% specificity for predicting insulin independence at 12 months. And that's important because I think what you don't want is just because this young patient presented with ketoacidosis to keep them on insulin lifelong. So you have to think about this. The other form of diabetes, which is the monogenic diabetes, very different from autoimmune type 1 diabetes. But I can tell you, in this part of the world, it is highly prevalent and we need to think about it. And I say that because from my own experience coming to work in Qatar, I've discovered at least 12 young people over the last 5 years who were on insulin, and they were for lifelong insulin, and we actually did the sequencing and we found that they had monogenic diabetes. And of course, the key thing to remember about monogenic diabetes is that they will respond to oral treatments. So they will respond very sensitively to glycoside, for example. So the monogenic diabetes that we need to be aware of is, of course, neonatal diabetes, which will present less than 6 months. And this is an 82% detection rate. So these are specific inherited conditions which alter actually the beta cell function. And the key thing here again is exquisitively sensitive to sulfonylureas. So these are young children who otherwise would be destined to a life of insulin that don't need to be on insulin. And similarly, actually maturity onset diabetes of the young, 80% are misdiagnosed as either having type 1 or type 2 diabetes. Family history is positive, autoantibody status negative, and they produce C-peptide. And again, the common forms are the glucokinase, HNF1 alpha, HNF4 alpha, and HNF1 beta. And the key thing here is, again, beta cell dysfunction, which can be treated with sulfonylureas. Or in fact, the glucokinase monogenic diabetes, you don't even have to treat. They just have a slightly high level of glucose. Latent autoimmune diabetes in adults, we all are aware. And then what I want to finish off really with is it really type 2 diabetes? So when we see a patient who's older, we think automatically this is type 2 diabetes. But actually, this piece of work, which I think is an amazing piece of work, published now 2 years ago, looked at variants of type 2 diabetes. And what they showed is based on body mass index, age at diabetes diagnosis, HbA1c, the beta cell function, insulin resistance, the presence of autoantibodies, and genetic sequencing, they could differentiate patients not just to have type 1, type 2, or LADA, but actually to have 5 different variants of type 2 diabetes. And those variants were based on the presence or absence of insulin resistance or the presence or absence of beta cell dysfunction. And if you look, this is what you would normally say is type 2 diabetes. But there are variants in here, and I'll show you what they are. So you have the typical GADA antibody, which is the top one, which is now referred to as SAD, severe autoimmune diabetes. So here you have antibodies, low insulin secretion, poor metabolic control. But you then have, based on HbA1c, insulin resistance, BMI, and age, 4 further different variants of type 2 diabetes. And you and I recognize these patients because these are the patients that you will see in your clinic who are thin, right? They're not overweight, they're not insulin resistant, and yet we think that just because they present at the age of 45, they've got typical type 2 diabetes, but they don't. So they have insulin deficient diabetes, low insulin secretion, poor metabolic control, and they have an increased risk of retinopathy and neuropathy. We have SERD, which is the typical severe insulin resistant diabetes. This is the overweight individual who will have obesity, and they are increased risk of nephropathy. And then you have mild obesity-related diabetes, which is probably the one that we most commonly recognize, and then, of course, age-related diabetes, 39%. So, to finish off, diabetes diagnosis algorithm, really, if you have a patient with diabetes diagnosed at the age of 30 or earlier and treated with insulin, measure the urine C-peptide to creatinine ratio. If negative, type 1 diabetes. If positive, you have to think about measuring their antibodies to GAD, islet phosphatase, in terms of recognizing whether or not they've got type 1 diabetes or both. And then if both are negative, you need to think about genetic testing. I think I'll just finish there, actually. I think I've run out of time anyway, so that's probably enough. Thank you.
Thank you very much, Professor Malik. I have 2 questions. Can you elaborate on the possible role of viral infections in the development of diabetes, especially now we are in the era of COVID-19? And the second question, is there any role for the monoclonal antibodies in the management of diabetes?
Yeah. So, you know, Coxsackie virus, rubella virus, this has all been recognized for many years, actually. I mean, we don't really have very good mechanistic studies, but it's clear that there is